My session is on the impact of time relating to person-centred care. Now, I'm conscious that a lot of what I'm going to say has already been said, so I'm not going to dwell too much on it, because to tell you the same thing 3 or 4 times gets a bit wearing, doesn't it? So I might go fastly through some of the slides. This is the history of it. It's down 1950s, 1960s. I always thought it was a nursing thing, but in fact it was medics that first decided to look at this aspect of care. So I thought that was quite interesting, because I always think they're behind us in relation to the one-to-one and how we manage people, but they were ahead of us there. And you can see they were looking again at the mind and at the body. And then the WHO picked up on it, and they've got a whole strategy on it, which is very interesting and worth reading. And then it was changed from person, because it was patient-centred care, so then the move went to person there. And then it went to family-centred care, and you can see the people that they included in that family-centred care. But it was a change of how we looked at things. So you can see that the model of care changed. Like the leg club model of care has changed the way we deal with patients with leg ulceration. In 1987, there were these 8 principles, and they were called the Picker's Principles. And they're what people have been talking about all day today, I think, if you read them there, aren't they? Very similar things there. But that was 1987, so quite a way away with that. Then a group that I think we'll probably are all familiar with in wound care, the European Wound Management Association, they decided to look at this. And this document, I can recommend all the UMA documents. I found them to be absolutely super to read, very objective, very informative. And this is one that they did, as you can see, on person-centred care. And again, the bullet points are what people have been talking about today. But if you read this document's about the evidence behind it. And I'm going to share some of that evidence behind it with you as I go through my presentation. But that's well worth a read. But as I say, I find all UMA documents well worth a read. Free of charge to download, often in many different languages. Sadly for us, not often in Welsh. But there are many documents and they're absolutely superb. I can highly recommend them. So what does the literature say? So what Byrne in 2024 years ago, they did a literature review on person-centred care. As you can see, there wasn't much there, 17 articles, so that's not many to look at, but they came across, when they reviewed the literature, there were these core themes, and I'll go through each of these themes with you. And again, these themes are what people have been talking about, but put into thematic brackets here. So the first one you can see there is people. And I think that's quite nice, the way they talk about basic human kindness. And we've heard about being good to each other and good to people that we care for. About the uniqueness, and we've talked about individuality, haven't we, of people. And about this partnership, and we've talked about this. But they also emphasise the balance of power, to try and have equality in that balance of power, which is not always easy to do, I find at times. The second theme they came across was practice. And here they were talking about doing. So what's doing in relation to delivering person-centred care? Again, I think we've covered all of these before. And Gary mentioned the moral and ethical behaviour. So again, that's just reflecting what we'd heard earlier. Then about the space. And again, it's about the organisation and the organisation's values and whether you've given the space to actually practice this. It's what we should be doing, but does the environment we work in allow us to do this? And it's not always the way. And it talked about going the extra mile rather than a core competency. But I have to think I agree a bit with what Barbara was saying, that this should be a core and not something extra, which I think we all agree with. And the final sub-theme was power. And getting this balance of power. And that's not always easy, depending on an individual's circumstances at the time, their health at the time, the situation for the healthcare professional at the time. It's not always ideal all the time for people. So there is this thing about power. We've talked about people sharing and being part of the decision making. And with empowerment, we have to remember there's sort of 3 stages to empowerment. So you might do your marvellous assessment, come up with a plan of care that you've mutually and jointly decided upon after looking at all the different options. and that might be fine, but then the individual will say to you, that's grand, absolutely fine, but you do it. I am not up to it at this moment in time of doing it. Then there'll be the other end of the scale, where you'll come up with the plan, the assessment, the plan, and the individual will say, fine, you've told me that, I feel I know what you're talking about, I feel I have the competency, the skill to do this, I don't need to see you again, I can manage myself. And then there's somewhere in the middle. And someone might say, well, it's new to me, so why don't you do it for the first 2 weeks, and then I might start doing it once a week until I feel able. So with empowerment, we tend to think of it as a single thing, but it's a state of flux. And people can move from one end to the other, back to the middle, back to one end. So what they decide initially doesn't have to be where they end up. They've got the ability to move between these different levels of empowerment, depending where they are in their lives and their circumstances. And again, power to practice. And with those things there we've already covered, I think. This was a nice piece of work done by Kwame and Petruka 3 years ago. And what they looked at is what communication skills do you need to implement person-centred care? Because we've talked about, yes, you can do this, but are we all necessarily that well prepared for it? And what they found when they spoke to patients is they said it was more important was the way people communicated and spoke to them than what they actually physically did to them. So their emphasis was much more on the communication than the actual physical interventions. And again, those second bullet point there, to me that is general politeness, isn't it? It's what we all expect from each other, I think. But again, Gary mentioned complex care early. And they say that we, in our position as nurses or healthcare professionals, we're there to help navigate that for people because it can be quite complex. So that's part of our role, is to be an advocate in order to achieve person-centred care. They came up with the barriers to communication, and we've looked at some of these, and we certainly looked at some in our workshop yesterday. And there are different barriers there, and I'll go through these individually now. So the institutional barriers, well, didn't we hear this yesterday, today? Yeah, it's going to echo with us here. Nothing there, I think, that we haven't already heard today. Cultural differences we perhaps haven't emphasised as much, and non-verbal communication. And that machine that you see there on the slide, that's what we have in the cancer centre where I work. And it's a translator on wheels. Has anybody else got these where they work? Yeah. So if we have people in and we need to speak to them and we've got no one that can speak that particular language, we've got this machine that will translate what you say to the patient. So it's a marvellous thing, because again, if you think in the cancer centre, when people come into us, they normally have cancer, they're normally very distressed, they're going through a difficult time in their lives, and they need good communication. Yeah. So we've got this machine to make sure that we can make sure that patients get the correct communication, or communication that they can understand. So these are really worth having. Our translator on wheels. The environment, and that picture there is the cancer centre where I work, which is a beautiful hospital in Cardiff. But I would say to you, I spend most of my days there finding patients who are lost and taking them to the right department. It's like a rabbit warren. You cannot find your way around it. It's really difficult. And again, locating departments, coordinating and integrating services. I'll show you an example later on of where the coordination has been absolutely spot on, but ours is like a rabbit warren. It's not necessarily noisy and it's very welcoming, but you can't find your way around it. And again, when we're having to give people bad news, those curtains aren't brick walls, are they? People are quite often too poorly to be taken to an area where they've got total privacy, and yet we're having to give them horrendous news sometimes. It's not ideal. We're looking into, and I don't know, I can't work it out myself, but they are looking into soundproof curtains. But to me, surely they can still hear because it goes up the top above the curtain. But I don't know. Medical technology, we're having a look. All the barriers to communication. The one that I thought I found was interesting when I was reading this paper was coercion. And I have to say, I think in my nursing career, I might have coerced people because I thought I knew what was best for them, and I might have tried to talk them into it. But again, perhaps that's something that I will reflect on more and more in my own communication skills. But I think in the past I might have tried to talk someone into it just because I thought it was right. I don't know if I can see a few heads nodding, so I won't be at the NMC on my own then. That'll be good. Yeah. And also I thought low self-esteem. I hadn't thought of that. And quite often when I see people with malignant wounds that are physically horrendous to look at, horrendous to live with, that person's self-esteem is normally quite low. Because what was there when they were intact and their skin was intact, that's all been taken apart, and it's not a nice place to be. And it does affect their self-esteem greatly. But I hadn't thought that that would necessarily affect the communication skills, but that's made me think differently. So facilitators, well, I think that's nothing new there, is it really? We've heard all this today, haven't we? There's none of those that we haven't heard already. This is a paper by Green, and this was an interesting paper. So they asked individuals with leg ulcers what they thought about leg ulcers and what their concerns were. And they listed things like we've heard: pain, exudate, odour, depression, anxiety. That was all there. And then they saw that patient with the district nurse or the clinic nurse or the hospital nurse. And they had a look to see if the nurse communicated with the patient and picked up on their worries. And you can see there, only 38% of concerns the DNs picked up on. And of the ones that were raised by clients, look at that, 80% of them were just ignored. 30% were discussed, but no solution was offered. And 18 completely managed well. So we talk about communications if it's always going to go well and easy and have a good outcome, but this paper shows that it actually doesn't always have that positive outcome. So we have to be aware of that. And the things that were difficult to talk about, emotions, they tended to be overlooked because it's easy to talk about how wet is your leg this week. So again, bear that in mind perhaps when you're communicating with patients. I thought that was quite interesting. But there's one positive there, isn't there? Look at that on wounds. We did better than half. Yeah. This was a randomised controlled trial. I didn't expect to find any RCTs on person-centred care, but I found this one, 2014, so not a recent one, but it was one of the ones I found. And they had this prefer care compared to standard care. And on the slide in front of you, you can see what preferred care consists of. So lots of things that are person-centred. Yeah. And what they had was this model. And they used this model of the 6 S's, because this was palliative care for cardiac patients. And these were the 6 S's that they actually based the care on. And again, this comes through in the person-centred care. They measured people's health-related quality of life using validated tools. So they were collecting the data, as Claire was saying earlier today. And they also looked at symptom burdens in these patients, palliative heart patients. And what they found is that when they'd use this person-centred care, you can see there were significant improvements in their health-related quality of life and less morbidity, less hospitalisation, and their symptoms were better managed. So it was quite nice to find this kind of quantitative work, because a lot of the work on person-centred care is qualitative. So it was nice to see the nice mix like you were referring to earlier, Claire. There was a paper then by Stanton on concordance, and what they found there is they were looking at using person-centred care to see if it would help concordance. And you can see what they did there. And they assessed, they collected the data, and with using person-centred care, they found the concordance went up to 90%. Well, I'd be over the moon if I could get concordance up to 90%. So it might be worth looking at that paper to see how they actually achieved it, but they did. Again here, there was looking specifically at elderly individuals in this paper by Ebrahimami. And again, the only issue that I found interesting in this paper is that ability to let people choose, or people have the more involvement, at times the healthcare professionals they got a bit uncomfortable because they felt that sometimes people weren't safe, they weren't making the right decisions. But that's a whole safeguarding discussion and issue. But that was one of the things that was a barrier for them in delivering person-centred care sometimes, was they were worried the individual wouldn't be safe. But again, that's going away from person-centred care because that's their opinion, isn't it? But it was an issue for them in there. Now you can see a nice picture of a leg club. I don't know if it's pool. No? No. Oh, so it's not an award-winning one. But there we are. Okay. Yeah. Because that's what we see there, isn't it? That reducing social inequality, the social atmosphere, sense of connectedness, that's all there, isn't it? So this is what they say in the literature that you need to implement it, person-centred care. I think we've heard this already. I thought the leadership was important, powerful, resilient, inspirational and motivational. And I think that is important, isn't it? But the rest we've already discussed. And what time do you call this, Mrs. Lindsay? I'm halfway through. I thought it would be. Yeah. When you go through the UMA document, the UMA give us suggestions of questions we should ask. Okay. To change our language, so that the way we ask the questions helps to facilitate person-centred care. And there you can see what those questions are on there, and they're in that UMA document as well. So asking things about care. And it applies if they've got leg ulcers, pressure ulcers there. So just have a think, how are you well? How are you? Perhaps hone your questions a bit tighter, and that might help to get that conversation going. But they're all in the UMA document. When I read the code, it's full of person-centred care. And I wasn't surprised at that, because that guides everything we do, doesn't it? I'll just read to you. I don't normally read, but I couldn't get all this on a slide. You'd have died of boredom if I put it on a slide. The code puts the interests of patients and service users first. They say we should put the interests of people using or needing nursing or midwifery services first. We should make their care and safety our main concern, make sure their dignity is preserved and their needs are recognised, assessed and responded to. We should make sure that those receiving care are treated with respect and that their rights are upheld, and that any discriminatory attitudes and behaviours towards those receiving care are challenged. We should treat people with kindness, respect and compassion. We should avoid making assumptions and recognise diversity and individual choice. We should work in partnership with people to make sure you deliver care effectively, recognise and respect the contribution that people can make to their own health and well-being. Encourage and empower people to share in decisions about their treatment and care. Respect the level to which people receiving care want to be involved in decisions about their own health, well-being and care. We should act in partnership with those receiving care, helping them to access relevant health and social care, information support when they need it. We should use terms that people in our care, colleagues and the public can understand, and we should take reasonable steps to meet people's language and communication needs. We should provide, wherever possible, assistance to those who need help to communicate their own and other people's needs. We should use a range of verbal and non-verbal communication methods and consider cultural sensitivities to better understanding and respond to people's personal health needs. And we should check people's understanding from time to time to keep misunderstanding or mistakes to a minimum. Well, that's everything we've heard about over these last 2 days, and it's there in our code. So when we're talking about time to implement person-centred care, I think we're doing it already. I think the people I spoke to in the workshops yesterday, when they were talking about how they were managing people, all those values and things we discussed, I found were present in the people we were listening to yesterday. So I think about time, I think a lot of us are already there. I think what we need the time for now is to bring our colleagues along with us.